Okay, let's talk about pregnancy with COVID-19 infection, FOGSI GCPR guideline. The SARS-CoV-2 is a new strain of coronavirus causing COVID-19, first identified in the Wuhan city, China. It characterized by those person to person transmission are documented. Shortly, it was declared as pandemic. Okay, you know all these things you know. Then pregnant women are a special category in terms of the healthcare. They should therefore follow this guideline fastidiously. They can protect themselves by the motto do the five principal element for this. They should stay at home as much as possible unless there is a medical need related to the development of symptoms of infections related to pregnancy. Routine antenatal visits are to be deferred. If there is a minor query, it can be sorted out telephonically. Keep the traffic of home visitor including home personnel, maids, staff member to a minimum to avoid completely if possible. Washing hands, home hands, elbow, face. Washing hand frequently, properly with soap and water and alcohol based rub minimum for 20 seconds. Elbow, covering the mouth, nose, whether paint elbow, handkerchief or tissue while coughing or sneezing. Then the used tissue should be disposed immediately. This is an important respiratory hygiene. Avoid touching face, eye, nose and mouth with hand. Keep a distance of at least 1 meter from the next person outside or in the house. These are the 5 things they have to follow. Then the clinical presentation and effect of COVID-19 on the mother. The mean incubation period from exposure to the appearance of clinical picture is 5 to 7 days. Most of the people who are infected will show picture of at least blood test by 11 days of exposure. Pregnant women who are no more likely to get infected than general population. There is a less chance of infection in pregnant compared to the general population. At present, it appears that pregnant women don't have worse outcome or consequence of the infection with COVID-19 than the general population. There is a less chance of infection. There is no very worse outcome and consequence of infection seen in COVID-19 pregnancy. The majority of peoples pregnant in general population may be asymptomatic or present with respiratory symptoms, COVID-19 infections. Most pregnant women have to mild to moderate flu-like symptoms like cough, sore throat, fever. Few may have difficulty in breathing, shortness of breath. If the pregnant woman has a comorbid condition like diabetes, hypertension, obesity, respiratory disease, advanced age, then she is more likely to have a severe form of respiratory disease. Given that pregnancy is a known state of hypercoagulable state, and emerging evidence suggests that those who are admitted to hospital with COVID-19 are also a hypercoagulable state. So, it follows that infection with COVID-19 likely will be associated with increased risk of maternal venous thrombosis. So, because of the already it is a hypercoagulable state pregnancy, and then again the COVID-19 also cause hypercoagulability that increase the risk of venous thromboembolism. Reduce morbidity resulting from self-isolation at home. Hospital admissions is likely to increase the risk of further. Effect of COVID-19 in the fetus. Preliminary research has suggested that the infection is not transmitted from the mother to the child by placental transfer. However, there is emerging evidence that now suggests that vertical transmission is probable. Two reports are published. IgM SARS-CoV-2 neonatal serum at birth. IgM does not cross the placenta. Test method and facility. The current diagnostic approach confirms the diagnosis of COVID-19 infection in India is to detect the presence of viral nucleic acid. This is carried by lysing the virus in the specimen and amplifying the quantity of nucleic acid available. Nucleic acid amplification test. The test to be used for is real-time reverse transcriptase polymerase, which amplify the viral nucleus certain specific gene detected in the specimen. At present, the RT-PCR test is recommended by the ICMR. How the false negative test known to occur 10 to 30% cases when two serial swab tested RT-PCR technique. The result RT-PCR depend heavily on viral load, nature of the specimen. These are the positive rate. If we are taking the bronchoalveolar lavas, 93, sputum 72%, nasopharyngeal swab 63% positive rate. In the near future, serological testing is likely to be available in India. It is faster and cheaper than RT-PCR. Population level serological testing may be more feasible to see in the prevalence. We are seeing the prevalence, so serological test would be more feasible. Also, after 3 weeks of infection, RT-PCR would be negative, but serology would be give the diagnosis. Possible result intervention action summarize. Suppose the patient is finding this ICM, she has IgM negative and IgM negative, then she has no exposure to infection or exposure has been occurred less than 5 to 7 days ago. Clinical status, no medical treatments needed as they are usually healthy and asymptomatic. If they have developed the symptom, the test should be repeated. Suppose she has IgM positive, she has IgG negative, she has already infected. Recent exposure to infection within 7 to 14 days ago. Confirm the diagnosis by RT-PCR of nasopharyngeal swab. Medical care depend on the clinical symptoms. If she is ICM positive and IgG positive, both positive, then they have exposure to the infection 14 to 21 days ago. Confirm the diagnosis by RT-PCR. Usually they are on the road to recovery, so no need of medical treatment. IgM negative but IgG positive. Exposure has been occurred more than 21 days ago. Immunity has been already developed, so they are already recovered, so no need of any medical care. These are not infectious, but can get this individual. Can it get infection? The risk of transmission in the individual is low. Not likely to. This is the hotspot area. Symptoms and influenza. RT-PCR positive, then confirmed by COVID-19 case negative is susceptible. Then routine antenatal care visit as per social distancing, advised to minimize the number of visits to bring no need for liver house. Minimal level antenatal care investigation is necessary for low risk and asymptomatic uninfected women at present. The recommended strategy of antenatal care is to the conduct antenatal care visit by phone or video call, home blood pressure monitoring. Some visit may be deferred. Questions should counsel the minor element addressed. Ultrasound has been advised 12 to 13 weeks and 18 to 22 weeks in another ultrasound. Pregnancy visit can be timed with this sonography. The next visit can be at 30 to 32 weeks. Vaccination and antenatal blood and other investigation can be planned during this visit. Growth scan last times are advised perform only if indicated when advised fetal movement every day. For women high risk factor, the guidance by assessment of pregnant women not in labor. If pregnant woman is confirmed test with COVID-19 infection, then assess the systematic status. If they are asymptomatic, the woman should be quarantined in the hospital as per current practice. The measure to be taken discussed in the previous section. The number of increase the government deadline hospital admission to quarantine may change. She should monitor self-monitoring. If symptomatic, decision to be made as the requirement of hospitalization for the intensive care unit. If in very mild disease, the criteria home isolation. not meet, and hospital necessary, worsening feature of an individual who was in home isolation, presentation to the moderate to severe illness. Intensive care unit manages critical care, especially pregnant who meet any of the following criteria: if they have respiratory rate more than 30 breath per minute, oxygen saturation less than 93 at rest, arterial pressure, partial pressure of oxygen divided oxygen concentration at 5 to less than 300 mmHg, patient with 50% more than 50% lesion progression within 20 to 48 hours of long imaging, quick sequential organ failure assessment score so can be used to adjust decision making ICU requirement. Most publication of the oxygen saturation is less than 93%. Quick bedside assessment tool is also used for assess sepsis score. Typically, screening for the try is called the quantitative SOFA score. 1 point for each, 1 point for each, and 3 criteria. One is respiratory more than 22 beats per minute, 1 score, and altermental status is 1 score. Altermental status less than 100 mmHg. Systolic blood pressure then suggest score more than 2 is suggestive of sepsis and need of intensive care unit. Medical management. Supportive therapy should include rest, oxygen supplementation, fluid management, nutritional care. The treatment of COVID-19 infection have been attended to approach. The first one is the combination hydroxychloroquine azithromycin. There is drug available and cost effective in India. Other approach antiviral drugs, some which are not available in India. Hydroxychloroquine, the dose is 600 mg, 200 mg 3 days with male. Azithromycin 500 mg OD for 10 days. In this pregnancy and exclusion criteria, however, such both these drugs have been used in pregnancy during breastfeeding without significant effect on the mother and fetus. Antiviral therapy, lopinavir and ritonavir is a fast antiviral combination is obtained to COVID-19 infection. Other drugs like NSAID, these are the drugs used upon in the care of COVID-19 pregnancy symptomatic relief, fever, myalgia, paracetamol preferred drug, a possible ibuprofen and NSAIDs should be avoided because the concern about potential SCA receptor. Antenatal steroid fetal maturity recommended enhance the fetal long maturity. If you suspect preterm delivery between 24 to 34 weeks, antihypertensive controversy surrounding the use of SCA inhibitor, IRB, in the general population, especially the elderly with hypertension, pregnancy, these drugs not to be used. Antibiotics, suspicious secondary bacterial infection, appropriate to consider safe in pregnancy should be added. Oxygen therapy. There is difficulty in breathing, oxygen supplement, nasal trunks or mask may be added. High flow nasal oxygen 4 to 6 liters per minute should be immediately administered. Non-invasive ventilation can also be used. Should be rehabilitation considering the patient. ICU management. Estimate that 50% of COVID-19 individual need care hospital, 5% will need ICU management. Identify need of industry should be conducting team ICU expert carrying pneumonia and respiratory failure. Conservative management, the IV fluid strategy, antibiotic prophylaxis, bacteremia, early invasive ventilation mandated, long protective ventilator strategy, periodic prone positioning during mechanical little evidence prone positioning pregnant women. Pregnant women may benefit from placing the lateral extracorporeal membrane oxygenation. Now, COVID-19 breastfeeding and COVID-19 infection. If after birth, if the mother is asymptomatic, display few symptoms, removing indirect breastfeeding can be happened. Mother has cough, fever symptoms, dyspnea, newborn need or mother has infant separation, infant to give a pumped milk from mother. And dressing must during 6 foot husband. Management during labor. Delivery suite designated for this case with all isolation facility will equip to monitor care. This should not be part of the running labor delivery complex. Minimize the number of persons in the room. Healthcare team in PP, birth companion team in PP, routine monitoring protocol for high risk pregnancy, hourly vitals, intake output charting, fetal monitoring as per protocol. Minimize intervention if there are internals used only if the single use filter after birth is contraindicated. Cards of the conception is getting exhausted. Mode of delivery cesarean reserved for those with obstetric indication If she has severe disease, delayed cord clamping is recommended by RCHG. Vertical transmission has not yet have any problem. Surgical procedure designated OT, minimize the number of person in OT room, healthcare team in PP, plan ahead, eliminate the movement of the team in out. Anesthesia is general preferred. If general anesthesia needed, then ensure negative pressure in the OT through the pressure of extubation. Antibiotic prophylaxis is recommended. Category 1 class cesarean section may have delayed as the team need time to put on PP, prepare the antidote, which may need to explain post-op care as per standard isolation room, principal barrier nursing and universal standard procedure.